I am particularly excited today on Talk IBC podcast to have Dr. Wendy Woodward here. All of us say we have a rock star girl crush on you, and we really mean it. And not to any way dismiss your incredible ability as a physician, but you also get to know your patient's way very personal. So before we get started, I have to tell a story about a time I crashed into her office. Dr. Woodward was my doctor at MD Anderson in Houston, Texas. Not only was because she was the last person in my rotation being a radiologist, or if it's just the fact that I connected with her on so many other levels, but I had been to several funerals in a very short time, and every woman was really young. And I had not started this charity. I was running support groups, and I literally crashed into her office, pretty hysterical. The nurse took me down this long tunnel hallway, and I realized I was walking into this really important researcher's office, really losing it. And you were busy and you had your back to the door and you were typing something. And I said, give me a project. I just got to do something. And you slowly turned around and smiled. And I remember what you said. You said, I've been waiting for you to get mad. And we started talking projects that led to the charity. So I owe you a huge debt for my life, but also the fact that you gave me the confidence, the encouragement to do something else. So Dr. Wendy Woodward.
Thank you so much. And thank you for sharing that story. It's been a pleasure, both to take care of you, but also to work with you for the last decade. You are a force to be reckoned with, and it inspires me, and it's given us so many ideas and directions to go in. So it's just been, I think, fate.
Well, I'm thrilled. I didn't mean to take so much time of that story because I didn't do a proper introduction, but I feel like everybody knows you. Your name goes around the IBC circle so much, but I know you were Dr. Wendy Woodward at MD Anderson. You are a radiologist oncologist, and you now have a new appointment there. Would you like to tell our audience about it?
Yes, absolutely. So you certainly know this, and probably everyone does, but I have been involved in the inflammatory breast cancer program at MD Anderson since it started when I was a very junior faculty. And I started working with Dr. Massimo Cristofanelli when the program first opened, and have been just absolutely thrilled to partner with Dr. Ueno for the last decade. I have served as the deputy director in the program for that time. And as he transitioned into his next phase, it has been a complete honor to take over as the executive director. And I can say, while I am so extraordinarily proud of what we had already accomplished and where the program is, and just the incredible infrastructure that we have to help to support education and research and clinic and all of the things, I'm also really excited about what we can do. I obviously, we all have ideas, right? And as you're watching and you're thinking, oh, we could tweak this, we could take a fresh look at it. That's what change is about. And I think as a program, we're all really excited about the opportunity to say what's great and keep that. And then what else are we missing? What could we be doing differently or better? And so I'm really excited about it. It's been an awesome whirlwind of a couple of weeks now, maybe 6-8 weeks.
Well, I can understand what you're thinking, some of what you're saying here, because the program started in 2006, and the infrastructure for the Morgan Welch Clinic is a very unique story. We could do a whole podcast just on that. We really probably should, to get that history locked down really tightly. But I feel like with the IBC network, we've just scratched the surface of what we can do. And I can think of these 15, 16 years since the program has developed, you have learned so much more that maybe in some ways you might even feel that way. I know well treated IBC before the program, but once that official program happened, do you want to address some of those changes or developments for
Sure,
people who might not know?
I think that some of the things that really come from having that dedicated program is that you're able to see through volume of patients, what the trends are that you wouldn't notice if you're one of 30 people seeing, maybe 30 patients a year. And so some of those things that have been really powerful are understanding, first and foremost, does the staging system capture everybody? That's a huge piece. And the staging system is a lot about redness. And we still catch ourselves saying red breast. But I've met lots of women who we strongly believe have IBC. They have a diffuse breast cancer that involves the whole breast, and it's thickened the skin, and you can see the skin's changed. But not everybody's change is redness. And I don't think we would be in the position to really start to have that conversation and do what we can to change the staging system if you couldn't see really in a concentrated way, what does that look like? That has led to the ability, I think, to think about how do we diagnose it better? And so I know that there's a project that we're doing in collaboration with Dana-Farber that's supported by the Komen Foundation to ask, could we make better tools? Because once we can incorporate that, and it was such a joy to talk with Beth Overmore, for example, who was the director of the Dana-Farber IBC program before Philippa Lintz, who's amazing, has stepped into that role, recognized the same thing. When we sat in a meeting together and said, what are we seeing? She right away said, yeah, no, they're not all red, definitely not. And so that's a change right there that's so integral to what IBC is, that doesn't happen unless you really have the chance to see that volume.
I want to jump in on that because one of the things I heard when I was first diagnosed is that a lot of doctors would say if you didn't have that pill to orange, that you couldn't have IBC. Well, that's not an early symptom necessarily. That might be after 2 months.
Right.
We would like.
And I can tell you another thing that's happened through outreach and education, because it's snowballed. It doesn't just come from us. We in the beginning were like, how do we get the word out there? But a big part of that is the network of people who are engaged in IBC in a really focused way, including yourself and other institutions that make it pop up on the internet when people start looking, and that you can get to local news stories and things that are like, oh, that's what it is. But now we actually see patients who have the perfect story. I had this classic inflammatory breast cancer syndrome pop up. I looked it up on the internet. I thought, oh my gosh, it could be this. I called my doctor. My doctor was like, yes, it could be this. They ordered all the right things. And here I am, bam, with this diagnosis. That's not your story, I know. And for sure, that transition is a piece that's come out of having these kinds of dedicated centers in our centers to be able to make that awareness happen.
I hear more stories like that. Unfortunately, though, I still do work with women who are misdiagnosed.
Of course.
And it doesn't seem to be, small town, large town type of thing. It just is what it is. But we are seeing more women diagnosed.
Yeah,
quicker.
So we do see some early patients who don't have peau d'orange, but clearly have inflammatory breast cancer.
Well, so we've got a few things we're going to talk about. Obviously, we talked about the fact that you are now the executive director. Can't wait to see what kind of changes are happening. I would like to talk about some of the big picture plans that you have for the clinic that you can share. You've already alluded to some networking going on with other institutions, which didn't used to happen, which I think is an incredible thing for all of us. And then also research, but I have a little pet peeve that often people will tell me, my doctor said, save rads in case you need it, or whatever. So those are kind of some of the things I want to touch on. So where do you want to start?
Those are great. Why don't we start with some of the program steps and just go in the order that you brought them up? I definitely want to get to the radiation piece because for sure for IBC, don't save it. Everybody needs it.
Everybody needs it.
Yeah, but let's just think a little bit about, or I'd be happy at least to share a little bit about what we're doing and focusing on as we move forward. Something that we started a year ago was to really do a strategic planning process within our program. And incorporate all of the members of our program. We have over 50 people who participate across every discipline at every level. And so at the same time that work was going on, we also initiated an internal advisory board meeting, a retreat, where we invited some of the really stellar scientists and leaders from the institution to come let us share what we are doing and what we have accomplished, and highlight what are opportunities that we're missing. What else could we be doing? And so that has allowed us to finalize our strategic plan, which the strategic planning committee, which is a very diverse group of people from every area, took all of that feedback and created the strategic plan in the same model that MD Anderson has made their institutional strategic plan. So leveraging all of the ideas about how to do that effectively. That was finalized. We have presented it at the executive committee, which I lead. It was approved, and we'll now in the final stage just open it up for feedback from our full membership and program, and then finalize that. And the 5 really key aspects of our strategic plan really center around the ideas that we need to be more patient-centric in the way that we think about how do we develop trials for the patients that we see mindful of how long they can be here, mindful of what they need, how well do they do with the current therapies, what are the gaps, and really tailoring that. So one of our first initiatives is to really look at how do we make sure that the patients who are in our vicinity, 150 miles, who might get their care anywhere, come and get it with us, partly because we think we're great at what we do, but importantly, because those are patients who could actually then get the opportunity to be on a trial where you're trying a new therapy. And that really can change the standard of care, but only if we get enough patients on the trial that we actually conclude, right? That we come to a conclusion and say, yes, this new therapy was better or worse. So in order to really impact, we have to accrue the trials. And those kinds of trials, we have one, for example, that comes out of the work of Dr. Wayno's lab, adding panitumumab, which is an antibody therapy. It's weekly treatments for 12 weeks. A patient who's flying in to see us from Michigan will not be able to stay and get weekly treatments for 12 weeks most of the time. So if we want to be able to accrue that trial and really answer a question, we've got to make sure that all of the people who are around us who could come and get treatment with us and hear about that trial and think about whether they want to be on it, know that we exist. And so that's one piece.
I want to jump in on this right now because, I live 20 miles from the hospital, and I was driving back and forth, and I've had people tease me and go, how many hospitals do you drive past on the way to that hospital that, by the way, have free parking? And I would just laugh and go,
Right.
You know what? I am going to that hospital because I have a rare disease, and I know I am being benefited by the research that was conducted there. I don't think the standard people realize how long it takes for research to get out to the general public, how long it takes papers to get published, the trouble and the difficulties of enrolling, just recruiting the patients you need to enroll. I wanted to do everything I could, being a native Houstonian, to get as close to that research as possible. I know I benefit for somebody else, and I know the chick in the other state's going to benefit from this. So I really want to throw in a quick little call to action. If you are in the Houston area and MD Anderson is local to you, see what you can do. It doesn't mean you have to give everything up at your other locations, but maybe you can support something here.
Yes, that's one of our goals too, and I'll talk about that too. We want to partner with local oncologists so that we can, again, help to learn everything we can, help to make sure people get the right care. Right now, we still have a gap in trying to push what we've learned out into the community broadly, nationally, into our network. And so that's going to be a huge piece of what we want to do. Can we define operative standards? Can we define radiotherapy standards? I'll talk a little bit about what we're doing in that space because there are some things we can do. But in the meantime, I had a wonderful conversation with a patient's physician, radiation oncologist, and she was from, I want to say, Montana. And I spoke to her physician, who sounds like an incredibly competent, really sharp, just state-of-the-art physician. And we were chatting, like, does it make sense? This patient has kids. Should she really come down? And I said, I would be happy to just go through. I can send you the constraints for what we could do. I can tell you, I'd be happy to even QA it for you remotely, look at her plan. I said, but, at the end of the day, I can now recall everyone who has had their disease come back in a place that we wouldn't normally have treated, that now I treat, right? Every nuance that I have implemented into how I design a radiation field comes from this high volume that's hard to just export. I don't have a piece of data that says, well, Mrs. M ended up right above where my treatment was, and that came back, and I don't want to see that happen again. And what she said to me was, I mostly treat GYN, because most of our local rad oncs are not specialists. They treat usually a range of things. She said, I mostly treat GYN. And I hear you. I feel that way about GYN. I treat so much complicated GYN cancer. I do feel like, I know exactly what you're talking about. But she said, I've never treated this. Here's what we would standardly do. It sounds like it's way too small for what you're talking about. And if you really have a method and a system and a way that you do it, I think she would be better off to travel there for 6 weeks. And she came. It's not possible for everybody, of course. And I want it to be the case that we can help to figure out how do we transfer those things so you can get the right care anywhere. But for right now,
well, and that's one thing I think is That's one thing I think is exciting here. You mentioned Dana-Farber or different places that you're working with, but also you've got the MD Anderson Connect. But when you say high volume clinic, I don't think people realize what that means. I think they just think you mean a lot of people, but you guys are seeing a lot of IBC patients.
Yeah, I mean high volume IBC. And the same, my uncle needed a valve transplant. He lives in a small place. I said, you need to go to the biggest center near you that does a lot of valve transplants, right? Like you want to be the high volume for that thing. And it has impacted us to be high volume for IBC. And we saw 3 IBC patients this week in multi-team clinic. I saw 2 more IBC patients in my own clinic. I was thrilled to see a patient with incredibly advanced disease diagnosed postpartum 5 years ago, who's NED 5 years later, has had a new baby since then, is doing great. It's such a joy, you know, and so that's what I mean.
You're talking about what you've seen in a few days that many places see in a whole year. Right. And that is a learning curve that I want people to understand that a place like yours, and I think Dana-Farber is getting close, but still, you know, I always say you guys are Elvis because you are. Oh,
that's nice. They're great. I have we can go into that too. I have such a great relationship and respect for what they do. It's been
just. But I don't think people understand when we say high volume, they think, oh, it's just numbers. And it's like, no, this is a specialty clinic. And I've had patients tell me, oh, well, my doctor says he's treated this before, but how many times, how much? And I always tell women, particularly, you know, if you're going to get your kitchen remodeled, are you going to get the first bid and just go with one bid and not look at anything else? I think it's worth it with a rare disease to try to get close to a university-based center that has a low level of expertise to make sure, because you kind of only get so many shots at this. And I know I was very fortunate. I didn't live very far from MD Anderson. But still, I think this is worth a visit. And then also like the relationship you have with his doctor, the fact that we're willing to talk and go back and forth and then have an educated exchange. Because I have had patients tell me, well, my doctor says we all go to the same conferences, but IBC isn't presented.
Yeah.
So that's a gap that we as a patient don't know.
Yeah, a couple things. One, I do think if you're close enough that you can do it, you're probably going to feel like it's worth it. And we are going to offer you a trial if we can, so that we can help to make things better. And so there's really that double bonus for doing it. The second thing, though, is that it is incumbent on us to make it so that we can help patients wherever they are, because it just isn't feasible. And so the 2 things I want to think about for us in that moving forward, one is, how do we partner with your local oncologist in a way that's safe? And I will tell you, the vast majority of oncologists, especially the medical oncology community, is so willing to have the input of our medical oncology team if it's needed. It isn't always, but if it's needed, and partner in that regard so that you can figure out what can you do standardly where you are, and what not. And it just depends. We saw another patient from a really remote community on the West Coast, and she just had such a limitation in what medical care is available in the region. There's just not a lot of great options. And she ended up getting chemotherapy. They didn't have the teams that help you try to avoid some of the complications that come with chemotherapy that are even just standard, not unique to IBC. So she hadn't gotten through all of her chemotherapy. She would have a toxicity and the whole thing would be canceled. And so having that sort of partnership, Dr. Valero, Dr. Lehman, so happy to reach out. Dr. Valero will give his cell phone to the patient and say, give this to your doctor, and they'll call and we can work that piece out to help people be able to do whatever they can remotely. And we want to be able to make it easier to do that kind of thing for the local therapy pieces, surgery and radiation, which are very operator dependent, skill in your hands sort of things. And one of the strategies that we have been working on with that is to partner with people who are interested in becoming IBC educated, high volume sort of nodes in other places. And so we can come back to it, but we have built wonderful partnerships with our network around the country with a small group who said, yeah, I really want to be the IBC expert.
When you say the network around the country, you're talking about MD Anderson's IBC Connect and network?
IBC Connect, and that's more than just MD Anderson. I'm thrilled that we 16. Have partners. Yeah,
aren't there like about 16?
Part of our MD Anderson community, and we welcome people to do that. We have a group from MCW. We have folks that call in who, say, I see not that many, but enough of them that I'd be happy to be the person in my area who does that, to begin to build that. So I think that's been great. And I look forward to leveraging some more of that, so that we really can begin to have folks all over who would say, yes, I can do this. And in the situations that are complicated, let me tell you what trials they have at MD Anderson or Dana-Farber, or a place where you could get some unique treatment that you can't get somewhere else.
Well, I think it's very important for people to see that, because I think it's important for them. And sometimes if you've never been here, you have no idea just how massive this is. I mean, people just assume it's, and I've picked people from the airport before who told me, I'm from a tiny little town of a few thousand people. It's, oh, I'm going to come get you because your brain's about to pop. When you see that the medical center is as big as downtown Dallas, and you can actually see it from space.
Right.
It is that big, that to see how you're sharing and connecting to make patient care easier, because you shouldn't get to live by your zip code rules, which is tough. But I know there are things that people have fear about radiation. So I don't know if you want to skip to some of the standard of care stuff to talk about that.
Yes, but actually, let me give a little summary kind of the,
please,
to close, what we're thinking about for our sort of strategic next steps. We want to reach out to the folks who can come to MD Anderson and get their care here, and have trials designed for them that will allow us to look at a new therapy. How do we help if chemotherapy hasn't done a great enough job, those kinds of things. But recognizing that we see folks who we're going to partner with and they get their chemotherapy somewhere else and might just come here for surgery, or just come here for surgery and radiation, maybe coming for the specialized lymphatic bypass to try to reduce side effects, any of those kinds of things. We want to develop trials for them as well, so that you could have a 1-point trial, and that's our 1-visit trial, and that some of those things could be around really raising the science, really making sure that we have very deep and robust data from specimens, from biopsies, from tissue, that we do a better job of educating patients about why tissue is helpful, what's involved in getting it, that we streamline it so we're never asking you for any extra uncomfortable things that we could be doing in a more organized way. And partnering with the institution, Anderson has these wonderful resources to be able to do really deep profiling of a rich collection of IBC patients at all of the different points of care that happen in someone's life with IBC. So that piece of it is going to be a huge piece for us. And then the last is really looking at how we build and invigorate our internal science program, so that that is feeding these clinical trials, so that we really have a very thoughtful clinical trial portfolio that's patient-centric and is catered both to the folks who are local to us and can come and stay and get their treatment here and maybe have multiple visits, but also to the patients who are visiting us and may only be able to come one time or only for one aspect of their care. So that's kind of our big picture. We've got a million initiatives going on and new trial platforms we're thinking about, but it's an exciting time. So I think that we'll have a lot to offer coming up.
Oh, I think you will. And one thing I really appreciate is if anybody ever gets invited to be on a committee, do it. I appreciate how much you give patients a place at the table. I think that it encourages us, it validates us. It's a way we can pay it forward. And, I had somebody come to the international conference, which was just hosted by y'all in Houston. And this one patient came who's also a nurse. She goes, I always thought there was this one lonely little researcher in the bottom of the MD Anderson basement, researching, and, because if you hear it's rare, there's not much funding going to it. And then I get in there and there's this room full of people and it's international and they're all working together. And she goes, I was actually excited to be there.
That's awesome.
And so I just think we need to get more people involved. So what?
Well, I know you know such a network of people who are interested in patients, and you've done such a great job of educating patients about being advocates. And I will tell you, we have, as a part of our strategic plan, initiated multiple new committees. And one of them will be our patient education committee, which Dr. Medigat Tashomi is leading, and you would graciously agreed to partner with her. We're going to start an outreach committee as well with Dr. Susie Sun has agreed to lead, and we would love to find folks who want to be on that committee. We will have a lot of emphasis on patient education, patient materials that we could absolutely use folks who are willing to read a thing and say, nope, that's not appealing, or I don't understand what you're talking about, to really help us to really meet the needs of our patients.
Well, I love it. And I am enjoying getting to do that. And I encourage people all the time. So if you shoot me a message, I'll make sure I connect you to the right person. So care. Oh, nobody dies of breast cancer anymore. It's no big deal. They catch it all early. Why are you worried? You're going to be fine. Your mammogram's clear. Go home, honey. How do we deal with that?
Yeah, I hope people don't say that. I think one of the amazing things that's happened, which is really good, is breast cancer is changing rapidly, and there are a lot of wonderful new drugs that are coming on the scene. And they are all geared towards trying to increase the number of patients who have this wonderful pathologic complete response. And one of the things that we have seen with IBC is that the chance of being cured after a pathologic complete response for IBC, while better than not having a pathologic complete response, is still not as magical as if you didn't have IBC. And so what we want to do is for everyone who gets into that great place of having the best response you can from chemotherapy, because if you're going to take chemotherapy or targeted therapy, it'd be great if it worked. And that's the sign that it's worked as best as we know that it can work. And then knowing that that is not the end of it, and that even with all of the therapies that we have, we still have patients who just very meanly, IBC comes back. It's so unfair, but it does. We want to know how we can stop that. And a big part of it is making sure that we don't leave anything on the table for these folks, right? I just today have seen an absolutely fabulous young patient who had the highest stage of disease there is, T4D inflammatory with neck nodes in the supraclavicular fossa. She's had a pathologic complete response. And absolutely, we don't want to say, great, and wait for that to come back. We absolutely want to make sure she gets all three of the critical big therapies that we have, systemic therapy, surgery, and chemotherapy, have all of them given in the most optimal way possible with the highest just degree of accuracy that we can do, not just don't give an inch. And we have really iteratively and incrementally brought the outcomes up and up and up, but we are not done. And when
Well,
you
also say for people who might not know,
you watch it slip away, and it is so heartbreaking.
I know. Well, for people who might not know, a complete pathological response is when you've had your chemotherapy and you have your surgery and there's no evidence of disease.
Yes,
correct?
exactly.
So
That's
then people might
exactly
go,
right.
great, I'm done.
Why do I need radiation? Yes,
Why do I need
absolutely.
radiation? And that's where I really want them to understand, because I hear a lot of times, oh, it's mop up. No, it's a trimodal. It's not a mop up. It's all three are important.
Yes,
So I'd like
they're
you to address
absolutely
that.
important. We know there are not studies in IBC where someone has said, let's compare not doing radiation and doing radiation, because the rationale to do radiation is so strong. We would never, without really, really new data, say, oh, let's skip it. So take a step back to patients who have much earlier disease, where people do trials where they say, let's flip a coin and say, should you have radiation or not? Or let's look at all of the patients who've had neoadjuvant chemotherapy and a pathologic complete response and say, should you have radiation or not? And the answer is still, if you started out with significant disease, yes. And that's for patients who had less disease than IBC. So if you would say to a person who had T2N1 breast cancer who had a pathologic complete response, that there's evidence that you can still benefit from radiation, and you would say to a patient with a T3N1 breast cancer, you definitely need to have radiation. And you'd say to a patient who had a T3N3 breast cancer, my gosh, absolutely you need to have radiation. There's no chance for the highest stage of cancer that you would say, oh, maybe you don't, right? That's not the place to give it up. If we were going to carefully ask the question, who can we omit it for? You'd start with the patients who have the very, very best outcome to begin with. So a trial that's asking that question is asking it in patients who have much, much less disease, and we still don't even have the answer. That trial has accrued, and we are waiting for the answer to ask, could we skip it after a path CR if you had T2N1 breast cancer? And I hope the answer is yes, but we don't know it today, so I would surely not skip it for T4N1, N2, and 3 disease.
Well, and IBC can't be seen until it's at stage 3, and it's known to grow fast. It's known to go rogue.
Yes, all
I'm helping
inflammatory
you.
breast cancer is T4D, the highest T stage there is. And it automatically is stage 3, which is right before you have metastatic disease that we know we can treat, but we don't believe we cure for the vast majority of patients. So that's just a place where don't leave it on the table. Do
Right.
everything
I'm
you
dealing
can.
with a young woman right now who had a complete response. So her doctor goes, "Oh, you're young. You don't need this." Well, it's been 9 months and she's full blown recurred. And she might have anyway, but I must admit, it's frustrating for me. I feel like her care was compromised. And now she's dealing with something and she will never know. It might have come back anyway, but at least do everything you can. So explain the process of radiation and what it is it does, because I think it
Sure.
needs to be given more respect than it's just mop up. That's not like you're
Thank
just
you. I
dusting off the
certainly
top
think
of the
so.
piano. No, it's more than that.
Sure. So one issue is that there are some areas of disease that are not going to be removed at surgery. So they are, if you don't do radiation, they are only going to be treated with chemotherapy. And there's no breast cancer, no matter how early, that we only treat with chemotherapy, right? There's not a time right now where if you had a T1N0 breast cancer, the smallest, earliest node negative breast cancer ever, that we think we can just treat that with chemotherapy. We don't omit surgery. So one issue is, let's say you have nodes in the supraclav, let's say you have nodes in the internal mammary. That happens a lot with inflammatory breast cancer. They will not be removed by your surgeon. So if you do not radiate those nodes, the only therapy they're getting is chemotherapy. The chest wall itself, the highest risk of having disease coming back after a surgery and chemotherapy without radiation is surely inflammatory breast cancer. We know there's a risk of that happening with relatively early stage breast cancer. After a mastectomy, T2N1 breast cancer, there's a risk, probably about 10%, that it comes back on the chest wall in a way that could have been prevented by radiation. That risk goes up the higher your stage of disease. Inflammatory breast cancer is the highest stage. We would estimate that the risk of it coming back on the chest wall with just surgery and chemotherapy is probably on the order of 50%. And I could look at some different ways to strategize. What do we think? We know how much radiation reduces the risk of things coming back where we radiate after surgery. And for most people, that's about 2/3. So you should be able to look at the risk of recurrence with radiation and say without radiation, it would be 2/3 higher. And across the country, the IBC risk of it coming back on average is about 20%. And so we would say it might even be 60% without radiation. In our practice, and I hope that this is going to be true nationally with improved chemotherapy, we do see that those risks are getting better with better chemotherapy. In our practice with surgery and radiation, we see that risk of it coming back on the chest wall or in those lymph nodes that the surgeon and I should be responsible for is under 5%. And
That's
by
mad.
not having it come back here, it doesn't get the chance to spread and become incurable. So that's a huge piece of just.
I've heard you
studying how
refer to removing that
away.
beehive of activity. That, you know, if you can remove that beehive of activity with the surgery and then radiate, you know, any little bit that's trying to slip away and escape and spread, it's not going to get to do that.
Yes, exactly.
I
And we
think that
know
people are worried
good
though
data,
about.
radiation improves overall survival because it prevents it from coming back and then spreading.
I hear people say, "Well, I'm worried that it's going to be uncomfortable," and I can tell you, someone had it. 6 weeks of radiation by you. You kicked my booty. That was okay. I got through it. Women get through it. And it surprisingly, when the skin heals up, you look down and go, wow, did that really just happen? Because it really does heal up. But I've heard women say, I'm afraid about my heart. I'm afraid about my lungs. I'm afraid about, and I think the precision when I remember, you're falling asleep on the beach when you were a kid and you get a tan line on your bun and it's just crisp. I
Yep.
remember my radiation field, that seam where the skin got a little bit brown, it was like that. It was crisp.
Yes.
The finesse of what you do is amazing. So when people have concern about their heart or their lungs or whatever, what would you share with them about that to help alleviate that fear?
I would say, first of all, that it's not a black box. We have really detailed personal information where we've taken a scan of that exact patient and we're modeling the radiation onto their perfect anatomy. And we can pull out all of the numbers. What is the average dose your heart gets? What's the dose to the big artery that runs down the heart? What's the dose that this percent of the lung gets? How much of the lung gets to the total dose? How much of it gets a small dose? And we have tons and tons of data that allow us to say, if you want to really say to this person, you have minimized their chance of having any consequence from this to their heart or their lung, you've got to get under this threshold. And we have lots of tools to do that. So for example, for the last 15 years, I'd say probably 20,000 patients with breast cancer at MD Anderson, we treat them while they hold their breath if there's any chance that would help to get the heart out of the way for a treatment that might be close. And what happens when you hold your breath is your heart moves away from the chest wall and it creates some space so you can treat what you're trying to treat and keep radiation out of the heart and make those constraints. You can't mess it up. Patients take a breath. It doesn't have to be a deep sea diving, heroic breath, anything like that, but just a comfortable deep breath. Diaphragm pulls down on the heart. It moves away from the rib cage. If you ever coughed or couldn't hold it that long, the machine turns off. It can see that your breathing bar has fallen out of the goalposts and it's not deep enough. And it's like, whoop, and then the therapist will say, oh, when you're ready, take a new breath in and hold it.
Well, I remember when I was in radiation, you made a special cradle that you laid in, so you were in exact position.
Mm-hmm.
It was such a fine science. And I saw a picture once. I'd like to get a copy of it again. Somebody shared it with me. It was their personal picture where it showed from their head going down all these colored lines of how deep the radiation went to their body. And
Yes.
it was a complicated map. And I thought, wow, this is just not shooting a beam through you and hoping you don't cook your back, It was incredible.
The technology that we're using now is even another step forward from when you were treated. We have started to use a technology called VMET, which is volumetric modulation arc therapy. And essentially, in the right situation, because many of the IBC targets the volumes we're treating, we treat all of the chest wall and where the surgery was, the nodes under the collarbone, the nodes under the breastbone. I pull all of the images they had up front before chemotherapy hopefully made it all go away. So I can map every single bit of disease. And often it'll be a big volume. And it's a little bit hard to figure out, how do I match all the different size fields to do that? So what we've been doing for the right cases is to basically tell the computer, here are all the things that I want to get this dose, this dose, this dose. Here are all the normal things that I want to get less than this, less than that, less than this. And the computer will actually generate a plan that drives leaves into the beam as it's coming out, perfectly matched to your target, your anatomy, your normal tissue, as the machine arcs around, so that you have the most even, perfectly targeted treatment that's meeting our low dose constraints and really trying to keep dose out of the heart and lung. And the nice thing about that is that it's a nice even dose. So little hot spots that cause, as I'm sure you know, things to be tight, things to be uncomfortable, I hope will be much less for people moving forward. I'm not always 100% excited about that technology for patients who are very, very young, because the consequence of the trade-off of having this beautiful, complicated high dose is you do get a little bit more low dose to normal tissues than you would with the treatment that we were doing 10 years ago. But in patients who are at least over 50 and probably over 40, it's probably still the right thing to do. And the reality is, if you were really young and it was the best way to get the best plan possible, still would be the right thing, and we'd figure out what to do about the risks.
That's interesting, because when I saw that picture, it just really meant a lot to me to see how much this is. But you mentioned about young and versus different ages. I know there's been some misunderstandings, like, I had radiation every day for 6 weeks. That's the standard for me. Sometimes people have radiation abbreviated time 2 times a week. And I've heard people say, oh, that's for convenience of travel or whatever. It's like, no, it's not. I would like to explain a little bit different why. So we might have a 2-time a dose versus a daily 6 weeks regimen.
Sure. So that at MD Anderson extends back to even before chemotherapy came on the scene. So in the very early days of MD Anderson Cancer Center, inflammatory breast cancer patients didn't have chemotherapy options. Those are big diseases, very difficult to do a surgery. And so their only option was radiation. And it was well understood that the biologic impact of radiation gets stronger the more you can squish it into a faster time. So if you take the same amount of dose and give it faster, it's going to have more oomph. So since they were doing radiation alone, that was the most oomph they could do twice a day. And so that was the standard. And they had some control with that, even in patients back then who couldn't get other therapies. As chemotherapy came on the scene and you start to see tumors shrinking and become operable, we moved to doing surgery where surgery was feasible, and then doing once a day radiation, which had become the standard. That's 6 weeks of once a day radiation. And what they saw right away was that you had a higher risk of having disease come back, even though you had radiation once a day in IBC than you did for non-IBC. So they said, well, maybe we should do that shorter, compressed twice a day radiation for IBC patients so that we can control that disease better. And that was effective. We got much better control doing it. Chemotherapy continued to get better and better. And so around 2000 or so, I would say we went back and we said, does everybody need this? Can we take a look at patients who had twice a day and didn't, and ask if twice a day or higher dose was better? And it seemed to be best or needed for patients who were under 45 and patients who didn't have chemotherapy, get rid of everything. So today, we still offer twice daily radiation to women who are under 45 or who have disease left after chemotherapy. And we looked back and said, okay, we switched to once a day when chemo knocked it out of the park for women who weren't super young. We looked and we said, was that safe? Were we doing the right thing? It looks great. We didn't give anything up. Those women who got once a day seem well selected. And the women who got twice a day don't have worse disease, don't have worse recurrences or more problems than women who would be getting it once a day. So that's a wonderful progress. And that's the reason we've been doing that. It's not randomized data. You can certainly find people who see a lot of breast cancer around the country who will say, oh, I don't think it's the standard of care. Maybe we need more data. When I look at the data retrospectively, I think there are definitely patients who need bigger and more. And I don't necessarily think that's the only right way to do bigger and more. But I do think you've got to know and be able to recognize this is someone who needs a little more nuance to their treatment than just standard treatment. And I'll say even the once a day patients, the particular nuance to doing that with radiation is you absolutely must go back to the original images, bring them in and fuse them and make a plan that's going to be bigger than what the standard treatment is. The absolutely wonderful woman that I talked to in Montana said, oh, we would have done what we normally do. And I can tell you those fields, which are great for less expansive disease, are not big enough for IBC most of the time.
No, I can imagine. And, you know, there's so many things I could talk to you about. We're getting up on 40 minutes already. And I'd love to talk to you about what it's like to be a radiologist who is having to radiate someone who had inappropriate reconstruction or expanders put in at their mastectomy, but that could be a whole nother program practically. But I see when you move, your boot walk shirt shows up. And so I don't know if there's anything else you want to talk about necessarily radiation. I think it could be really good to talk about the boot walk. What does that mean? What, are places that help you? How can we help? The boot walk is a unique program that MD Anderson started. So do you want to tell people about that?
Yes,
where do you want to go next?
Thank you so much. For sure, for any orphan disease, but certainly IBC, this has been true. Philanthropy and fundraising is a huge part of making progress. And the fundraising that IBC Network has done has been absolutely incredible for us. We were very excited when MD Anderson launched a program that allows us to raise money for our own research. And so 4, maybe 5 years ago, you probably can tell me better than I can, the Boot Walk was launched. And the Boot Walk is basically an internal program that allows people, teams, patients, researchers, doctors, everybody who wants to raise money for MD Anderson. And if you raise more than their sort of specific amount, you can direct it to the research that you want. And that's true as an individual. One of my colleagues wanted to raise money for lymphedema, and she managed to raise more than $10,000, which is what you need. So she has $10,000 that she can spend on a lymphedema project. In the IBC program, we have always been fortunate to raise more than the minimum that's required for the money to be directed to us. We have at times raised much more than $100,000 a year. This year, we raised close to $100,000 a year. It's been fantastic. And that allows us to have money that we can direct to really foster new research projects. It's great because 100% of the money goes to the research. There's no money that goes to admin. They have philanthropy that supports the actual whole project. And we have used that money both to support projects to help our researchers get the necessary early data to go out and compete for bigger grants. We have also used it to support our patients directly, so that if you could be on a clinical trial, but the expense of the hotel or the travel is really going to be a deal breaker, we can provide some support on that trial. One of our initiatives is to figure out how do we do more of that, because I never want opportunity, access, equity to be a barrier to people to be able to get onto a trial if they're interested in that. So that's been a huge win.
When I first got involved in this world, I just assumed that you guys were sitting on buckets of money. I know it sounds stupid, but I just assumed when you're at a university-based place, there's money that just comes with it. I didn't know how much y'all had to seek it out. I knew you had to write for grants, but I didn't know that meant if you don't get a grant, you don't have a job. And so that's what got me involved in wanting to be that the IBC network could give you maybe that seed money or that discovery money that could get you to the bigger money. It comes from the government or the National Cancer Institute or whatever. And I would like one day the IBC network to give the bigger money. But the boot walk is a really easy way for patients to get involved and support, and or maybe they can even serve on some of the committee to help decide how to spend it.
Absolutely. Yeah, keep an eye out for it. We welcome everyone to join us, to walk virtually. You don't have to raise money to be a part of our boot walk team. We're grateful for the awareness and the engagement. It's all really positive, but it's so
it is because there's no minimum, which I thought was really great. There's no pressure to raise a minimum. And one thing about the boot walk I was going to say is that know that 100% is going to go to the project and it's going to go to research. I just think it's a great way for someone who maybe is sort of a reluctant fundraiser or doesn't feel that their $25 is going to matter. Because I've been very proud that the IBC boot walk Wrangler team has been in the top 3 historically every year.
Yeah, and we're so grateful to the IBC network for their support, which has been both financial, and we appreciate the donations, but also just the engagement and spreading the word and being involved in our committees and planning, and all those things have been so important. And I'd just give you a shout out too. One of the other things that you do, and of course you know this, but that's so important, is that some of the junior investigators that you support, that grant really helps them to be seen in their additional grant applications, in their job applications, as a competitive candidate. And so certainly, you look at someone like Bizrat Debeb, who is just a fabulous scientist, so smart and so engaged. And
I feel like his mama. I'm so proud.
Exactly. And that money that you gave to support his research has definitely been a stepping stone that has allowed him to move forward and be competitive for grant mechanisms all over. And so, those kinds of things, I think people might not realize my $25 went to that, but it really makes a lasting impression.
It really does. And I'm really pleased you said that, because I know that, and you know that. I think most of us still think you're sitting on a bucket. And so we really want people to know about inflammatory breast cancer. You may say, well, this is a rare disease. How likely is I'm going to get it? But I really feel like if we can learn to stop really aggressive diseases, it will help benefit less aggressive cancers, hopefully. But also, too, to see the science emerge and what you learn, we all are going to get benefit for that. So what would you want to say as your parting message to our listeners today?
I would say, if you have the opportunity to be seen in a high volume center, you probably will not regret it. And we are grateful for the opportunity to be part of your team. If you are not, we are still willing to try to help and partner with these places. A huge part of our mission is trying to help all of the amazing physicians and teams wherever they are to recognize IBC when they see it and to be able to take care of patients where they are. And watch this space. I think that we will have a lot of excitement to announce in the short term, and look forward to making a difference for our IBC patients.
I love it. And you said something one day, did you say not rare here?
Yeah, it's not rare to us. And I think
not rare to you.
To the extent that we can help to take that knowledge that we have gained from seeing 5 IBC patients a week, and share it. That's what we want to do, and figure out how to be a role model for making a rare disease feel comfortable wherever you are.
I love that. Well, you've been listening to Dr. Wendy Woodward, who is the executive director of the Morgan Wells Clinic at MD Anderson, Houston, Texas, and my deepest gratitude to you for all that you've done for us.
Thank you so much for having me.
Thank you.